All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So today we have a friend, we have a very, very good physician with us today. He works in emergency. I was talking with him, I was making fun of him before, and I was saying, should I introduce you as we have Dr. John Bream, who works in emergency, also manages COVID, and has been silenced and suppressed and stopped from talking about COVID on Facebook. And he said, yes, that is pretty much it. That is the introduction.
that is pretty accurate. As you and I talked about earlier, our last attempt at going live was banned by YouTube. So despite the fact that everything we presented was evidence-based, we linked all the trials, all the studies in our slides. I think there were 22 studies total that we linked. YouTube within 24 hours said it wasn't good enough for them, and it was wiped off of YouTube.
Yeah. And so Cool Beans actually are aware of this, that I sometimes mention that I went on as a guest with Dr. John Bream, and then that talk was banned and removed. So here we have Dr. John Bream here. We'll see what happens to this talk. And if YouTube takes this one down as well, then hey, we'll be equal. 1 year old.
Hopefully not. Facebook did leave our talk off, which was nice of them, because like you said, everything we talked about was evidence-based and very accurate.
Awesome. So just another quick thing. We have a Discord server, and some cool bean put a link there, a picture there of one of my videos debunking one of the, those rumors nowadays and folks who generate those rumors. One such person, I was debunking them, and Facebook had put a tag on my video to say, this is fake news. So essentially they were saying, then that person is correct, the fake news person. This is how lost, I'm using a decent word so that this is how lost they are.
Right. So but thankfully there's good folks out here like me to try to keep the record straight and, keep the misinformation from, percolating out there.
Yes. So once again, thank you very much for being with us. Cool Beans,
thank you for having me again.
Yep. And Cool Beans, thank you very much for your time as well. The agenda for today is that I wanted to look at the COVID from the perspective of an emergency room physician. So we talk about, for example, this morning we talked with Dr. Chetty, and we talked about how a primary care provider looks at COVID and manages it. How about we look at from inside the hospital and inside an emergency room and see what are the doctors doing there? How are they looking at it? And then another thing that was interesting for me, I think it is also a topic that is sensitive for social media networks or these networks, but I think it is worth discussing. And that is the COVID long haul, and then post-vaccine symptoms as well. And full disclosure on my part, I am a pro-vax person and I have my vaccine. So when I discuss about those symptoms, the point is to figure out how to manage them, not to say stop the vaccines. So this is, I want to put that out there. But I'm very much interested to see how badly the people, Dr. Bream, that you receive, and they may have the post-vaccine long haul. And then finally, there are a couple of drugs that Dr. Bream actually sent over to say, hey, look at these drugs and their mechanism of actions. They are good investigational drugs for COVID. So we're going to talk about those as well. So this is the agenda. Once again, welcome, and let's start.
All right. Well, thank you for having me. So I'm a board certified emergency medicine physician. I practice at multiple facilities in North Carolina, in the eastern part of the state, and some in the Greensboro, Winston-Salem metropolitan area. Thankfully, I can tell you that the COVID caseload in North Carolina is currently very low. I think I looked yesterday. I didn't look today. I think we're under 300 cases per day, which North Carolina has about 10.5 million people. So it's a fairly low caseload. So thankfully, I'm not seeing very much COVID in the emergency department currently. I've seen a couple of sporadic cases. The cases I have been seeing lately are very mild, and people seem to be doing relatively well currently. So that's obviously great news, and we want to keep that going. North Carolina does have a pretty high vaccination rate comparatively to some of the other states in the South, so that does help. Much like Dr. Bean, I am pro-vaccination. although I do, evaluate the literature and know that there are some adverse effects and things that we need to keep in mind. As we talked about last time, I was a participant in the Novavax North America Mexico clinical trial, which we can talk about a little bit, but showed excellent phase 3 results. It's the only vaccine that's tested against the variants and did astonishingly well with 90.3% efficacy for symptomatic COVID-19 and 100% prevention of hospitalizations and severe illness, even against variants of concern. So I was very happy to participate in the trial. I now have a vaccine card, and that all was a great experience, and I'm very happy that I did it and I would do it again.
So were you, did they give you the vaccine or placebo when you were in the trial?
So they did a double-blinded crossover. So in January, I had my first dose of either vaccine or placebo in mid-January, and then had my second dose in sometime beginning of February. I think it's February 11th, if I remember correctly. And after the first injection, I really wasn't sure what I had. I did feel, I can tell you, when they gave me, as I get the flu shot every year for work, and so when I got the injection in my left tricep area, or left deltoid, and when they gave me the injection, there's a little sting there. I could feel it, all the way over toward my mid clavicle, and I was like, that's a little more sting than I had thought. And that's really the only thing I noticed that was different. And then the second dose I received within about 12 hours, I had a temperature of 99.4, and I just felt tired. I didn't feel sick. I didn't have a headache. I didn't have nausea, vomiting, myalgias, anything. I literally just kind of felt run down, and literally within 24 hours, it came and went as fast as it came on, and I felt perfectly normal afterward. And then, so after the first 2 injections, the FDA decided that they needed to do a double-blinded crossover, and so then I had to wait until April to get what I feel like ended up being placebos. I felt no effects. And then I actually got pretty sick at the end of May. I mean, sick for me. I had a fever of 101.6 for about 5 days, cough, congestion. I had to go back to the trial site. I had to swab myself for COVID 3 times. They had to swab me, do blood work, make sure my antibody levels hadn't gone up ensure there wasn't a false negative COVID test that I took. And then, so I couldn't get my crossover injection until the beginning of June. I had to be well again. And so I didn't feel it. So I feel sure I got vaccinated the first time and got placebo on the second 2 injections. And then they recently released their data. And as one of the cool beans mentioned, the Delta variant was not prominent during the trial. So that was not one that has been tested against significantly in the Novavax trial. But what I am seeing a lot of in the emergency department right now is I do see a fair amount of people who come in miserable with, post-acute sequelae of COVID-19 or, long hauler syndrome. I actually saw 2 people in my shift last night who came in with those symptoms. One was a younger male who had COVID about a month ago and just hasn't felt well since then. He's just basically been chronically short of breath. And he said his taste of smell recently came back, so it's about a month for him. And then another patient who received a vaccine about 3 weeks ago and just said she'd had headaches and dizziness and nausea and chest pain and shortness of breath that has been going on since the vaccine. And I don't want to say which vaccine she received. I don't want to spook anybody, but so I am seeing, and then as what I have seen in the past, I've seen a few cases of Moderna-induced SVT. I've seen some in cases of acute febrile delirium in elderly patients. They come in with fevers of 103. They're hallucinating. Not uncommon when elderly people have a high fever, they hallucinate and they're very altered. And just seeing some cases of some people, elderly patients who are generally so weak after the vaccine, they fall, they break their ankle, things like that are, well, not necessarily side effects of the vaccine, or, I feel like these people, if they hadn't gotten the vaccine, they probably wouldn't have fallen and had a bimalleolar fracture. So those are things I'm seeing in the emergency department right now. And it's sort of interesting as an emergency physician. You say you're talking to had a sounds like a general practice physician on earlier today. My ability to treat PASC in the emergency department is fairly limited. It's generally better treated in the outpatient arena, as you know, with some of the treatments that are being used. With Dr. Patterson and Dr. Yogendra and his crew are doing. I can't write you for Maraviroc and fluvoxamine and those kinds of things because you need lab monitoring, you need a physician following you, and so those are just not things that I can't write those for you and follow you up for them for a couple of reasons. One, that's illegal, and two, emergency department physicians just don't do follow up care in that regard. So I do think it's the PASC. What I generally try to do is educate them about their condition, validate that the symptoms they are feeling are very real, and that they are at this point not very well understood. Although I think Dr. Patterson, as I've got kind of poked a little bit of fun on Twitter, I think Dr. Patterson should win the Nobel Prize for medicine for what he's uncovered with long haulers. Especially with his discovery of persistent spike protein in monocytes. I mean, causing this this persistent inflammation in the body. I mean, I think that is just a major discovery that really is going to change how we approach these patients. But in general, I mostly just validate their concerns. I will let them know that there are some groups out there that can help them. And I do refer some of them to the long hauler site so that they can feel supported. But unfortunately, while I know what to do, it's just generally not in the realm of emergency medicine to do it. But I try to direct them in the right direction.
Got it. So I want to continue this part of the discussion, the long COVID, either after the vaccine or the infection. But I want to go back to Novavax for a second. Cool Beans are very, very interested in Novavax. I was very interested in Novavax. I believe you like Novavax as well. You are part of the trial.
Yes.
So if I can ask you a couple of more questions. One question that came from a Cool Bean here, so Patty said, Dr. Bream, why is it not going to be available here in the US?
Well, I think it will be available in the US. I think we're looking at September for emergency use authorization from everything I've read. It sounds like from what I gather from listening to some of the press conferences, it sounds like these applications are very long and very difficult, and Novavax is not a very big company. In fact, I would say they are a tiny company pre-COVID-19, and so they're having to build literally factories in Britain, factory in Czech Republic, factory in Canada. They've had all these supply agreements, and all these things are just difficult to set up. But to actually, evidently, to do the emergency use authorization paperwork, it's evidently a massive packet of paperwork they've got to do. And it sounds like the main issue that they're stuck with right now is proving that they have the manufacturing capacity to produce as much vaccine as they say they're going to be. And evidently, they're going to be around 100 million doses at the end of the third quarter and 150 million doses at the end per month at the end of the fourth quarter. So it sounds like the Novavax vaccine is coming. It sounds like it is going to be mostly a booster in America, but in parts of they are a huge part of COVAX, which is the international vaccine movement for a little bit poorer income countries. And that's going to be their major niche. So they'll be supplying, I think they have it's over 1 billion dose commitment to COVAX. And a lot of that will be, I believe, in India, because SII, Serum Institute of India, is one of their major manufacturing partners. So it should be available. I would say by the end, I would feel comfortable. Obviously, I do not speak for Novavax in any way, shape, or form, but I would say by Thanksgiving, I would feel comfortable. That's good. By the time October, November, fall, when we, I think, are going to have to start worrying about COVID a little bit more again, I think it should be available.
Got it. And I have a question.
Mm-hmm.
Almost for last few weeks, we have been tackling and discussing and becoming concerned or not concerned about the spikes. And it baffles my mind that folks actually believe that an actual infection spikes are less dangerous, but the vaccine produced spikes are somehow unlimitedly produced and they are going to be dangerous as well. Novavax itself is spikes. It's not even RNA or DNA or not even an inactivated virus. It is the spikes
It's a spike.
that are put together in an edible arrangement of a little particle. How will the folks respond to that and say, do you think that now we'll have a new problem at hand to convince that these spikes will not go around and cause issue? Or even if they go around, they are not going to cause issue? You received it, other people received it. What is your take on it? These are spikes.
I don't think so, because it's more of a traditional, protein subunit based vaccine. Very similar. They'll say very similar to the hepatitis B vaccine that we're given at birth. But I think I don't think that they have really talked much about their data, and I'll be honest, I've seen some of it, but I think where they're going to be able to market their vaccine to people is to say that, look at us compared to the mRNA guys, our side effect profile is roughly half of what their side effect profile, because they are using, spike protein. There have been studies that we have seen now that show you don't even need the core protein or all the other proteins of, SARS-CoV-2. The spike protein is enough. Like, all you have to have is the spike protein to cause all this inflammatory cascade, cytokine release syndrome. It literally is just all about the spike protein. But I do think they'll be able to point out that they're similar, if not better, efficacy against COVID-19. They're proven data against variants of concern, not just theoretical. And then they'll be able to point out to their 30,000 patient trial in America, their 15,000 patient trial in the UK, to say, hey, look at our side effect profile comparatively to the mRNA vaccines, that we have a much more benign side effect profile.
Got it. And I actually, once again, for the cool beans, these are spikes, correct? And
Yes.
maybe there will be some spikes that will break off and enter the blood or lymph and end up in the circulation as well. But there still are limited number of spikes. They are still going to be picked up primarily by the immune system, other cells in the local vicinity, broken down, presented, and immune training to occur. And the proof is that we have folks who took part in the trials. I am sure, Dr. Bream, and I have not seen their data yet. I have not seen that FDA type briefing. I've seen their press releases.
Mm-hmm.
They did have folks who are above 60 years of age. They did have folks with
Mm-hmm.
comorbidities, and it worked out fine.
Yes, and I think one thing they did, which I've been pretty vocal on my page about, that Pfizer and Moderna declined to do, was they did the phase 2B trial in South Africa purposely on people with HIV, which has now been well documented. That may be part of the reason, the reservoir for all these mutations. That they talked about that one lady had multiple different mutations and had persistent virus for months. But I think it's a very bold move they did to show that their vaccine could even be efficacious in patients in South Africa with HIV. Now, it was not nearly as efficacious as it is in immune competent individuals. The efficacy was in the 40s, which they would point to not necessarily as a failure, just that they would probably need a third shot instead of just two. But they at least were willing to take that risk in their 2B trial, whereas Pfizer and Moderna both recently turned down an invitation to do a similar type trial, which I did post about that on my Facebook page, Bream Medical, a couple of weeks ago when that came out. But they have made specific efforts to get into immunocompromised individuals.
Got it. And just for the cool beans, when I'm looking here, I'm looking at your comments to figure out what next question to ask. So I'm not ignoring you or Dr. Bream. And when I'm looking here, this is my site where I have various websites that I would open as we are discussing things, for example, for long COVID. So with this, so I feel pretty excited about Novavax. I love that. I had declared that love
Right.
many months ago, and I'm still in love with it.
And I think one thing I didn't mention that when you brought this up, they use a much lower dose of vaccine or the spike protein than the other vaccines use. They only use 5 micrograms, and then they have their patented technology that's an adjuvant to provoke the immune response. So they're actually using a much smaller amount of spike protein comparatively to the other vaccines.
Yes. And I read about that, and they said that because they have good adjuvant, which is chemotactic for immune system and kind of brings the cells over and activates them more, so they don't have to have a lot of spikes. They have less spikes, but more activation of immune system. And
Right.
that is how they are dose sparing vaccine, which is excellent.
Yeah.
I have a question here. Trillium says, I'm not an anti-vax, but I don't understand why more emphasis could be placed on prevention and treatment protocols. I get that the vaccines have its place, but why does it get more attention than good care?
Yeah, that's a great question. I don't know that I have a great answer to it. I do think there's certainly roles for both. Because as we are seeing with the Delta variant, there are more breakthrough infections than we were seeing with the Alpha variant or with the original strain COVID-19. I think there's a role for both. I think the argument for vaccination would be that, like we're seeing in Brazil currently, what happens when there is a very poor vaccine rollout is that you're going to just continue this downward spiral of COVID, and the more people that get infected, the higher likelihood that COVID has a chance of spawning a new variant that's going to be even more troublesome. I do think until we reach a critical mass of vaccination, that variants are going to continue to be an issue. And so I think, in my mind, that would be the biggest reason to focus on vaccinations. It's no secret that here in the United States, where the vaccination rate is much higher than elsewhere in the world, that we're not having nearly significant of issues as other countries. So I think us and Israel and some other countries have very high vaccination rates are proving ground that it does help to keep caseloads low. Although the UK is sort of an interesting, I would say, exception to that. But for whatever reason or another, they seem to get hit by every variant. Now they had Alpha, now they're having trouble with Delta. It's just very interesting and I'm not sure I have a great explanation why the UK is struggling more so than the other places.
Is it?
But
quick comment. Sorry for the interjection.
Oh, you're fine.
Is it that the UK is struggling with it, or is it that their media and their folks are actually creating too much of noise about it? Maybe it is the right thing to do to make that noise.
Yeah, and if you look at their numbers, they're still quite low. I think there's a big difference if you have 50,000 cases and you have a 40% increase, then that's an increase of what 20,000. Whereas if you have 12,000 cases and you have an increase of 40%, then your increase, you're up to about 3,000 or so. So while the numbers are, the percentage numbers are the same, the absolute numbers of cases would be much different. Now, those are numbers I came off the top of my head. I don't know that's exactly where they are.
So I thought I'll actually share how UK is doing. So this is the part that the media has been running with to say, and this is not incorrect. Media has been saying that, hey, we had gone down to 1,500 per day to 1,800. And now we have jumped back to 10, 11,000 per day. So 4 or 5 times the increase in cases because of Delta. I think that there is an additional piece to see, and that is the number of deaths have not gone up. And I fingers crossed, I pray that they do not go up. I'm not going to sit here to say they should go up to match the damage there. Maybe the damage is not that much, and that may be a good thing. Now,
Yeah, I think that's an argument that a lot of people, I think we seem to get lost in, is that the goal of the vaccine is to not die. The goal, granted, it's great to not get it. But the goal is to not die if you get COVID. I'm very interested to see, and I don't have any data on this at all. It's sort of just freewheeling here. These people who are vaccinated get breakthrough infection, what their PASC rate is comparatively to non-vaccinated individuals. I think that would be very interesting to know.
And PASC is post-acute
sequela COVID-19 or long haulers is
correct.
Pretty much
I just wanted to make sure that. So I want to do one more thing. So as we talk about US and Israel and UK, we should look at India as well. India is an example where there is not sufficient vaccination.
Mm-hmm.
And they were doing badly a few weeks ago, but they have very decently. Let me so look at this. This was a scary bump for India, and they just came down so fast, which is excellent. Again, fingers crossed it continue to come down and continue not to have more issues. I think that so vaccination is not a big deal there at this time because vaccination is not enough. It is, I think, lesser than 10%. But ivermectin, then people may be looking at what is going on, getting scared, and then doing more social distancing, behavioral changes. I think there's a combination that also helped here. What do you think?
Yeah, definitely. And I think there was, while it's not a randomized clinical trial, there was the data that came out that showed when they deployed ivermectin in Delhi and in Mexico City, the severe rates, the cases, the hospitalization just plummeted. You showed watched one of your videos not long ago where you talked ivermectin. You had, I think at day 6 and 8 had significantly decreased viral loads comparatively to placebo in a trial. There's now some consensus I posted, I believe yesterday or the day before. There are now some meta-analysis reviews that give at least moderate quality evidence that early treatment with ivermectin could be beneficial. So I guess that we would call that, in medicine, you have, grade A, grade B, grade C evidence. That's probably a grade B, moderate quality evidence. Grade A would be high quality evidence. Grade B would be moderate quality. Grade C would be low quality evidence. So, because some of the things are low, so I'll call it B minus. We'll go there.
Yeah. I know that meta-analysis came from Dr. Teslari. She would be here with us in a few days as well. What is more interesting for me in her meta-analysis is that the death rate or the likelihood of death was reduced significantly. Mm-hmm. So even if, let's say, the infection is still there, so if ivermectin can help bring an infection to a point of common cold-like outcome, and again, it is not 100%. The efficacy is somewhere about 74% or so for prophylaxis, and the likelihood of death is reduced by, I believe, 60 to 70. I think that likelihood of death reduction is a very important thing. Mm-hmm. What do you think?
Yeah, I agree with you. And because, essentially, this ivermectin data is exactly what we're targeting with polyclonal antibodies. It's exactly what, molnupiravir is targeting. And I guess I'd say on the record that, is that the reason that ivermectin is being squashed? I don't know, but, that's as good a theory as any, I would say. But, it essentially accomplishes the same goal for, $20, where all these other drugs are thousands of dollars. So I don't know, that's just a theory. I don't think there's necessarily any, malfeasance going on, but I do think it accomplishes the same exact goal. That's what we wanted to see with the monoclonal antibodies. that we are, people getting sick, they're getting the IV infusion, and they are, not getting hospitalized. That's exactly why they got UAs.
And I want to say this. I had sent a quote to a newspaper a few days ago where I had said that Merck has essentially copied our ivermectin's mechanism. And so some people took it literally and then argued back and said, well, these are two different molecules and their mechanisms are different. And that RDRP disruption by molnupiravir is through the RNA raw material to be incorrect. And the way ivermectin works is it blocks the RDRP by binding to it. And they said, so Mobeen is wrong in saying this. My point was, from a high level, they both are disrupting RDRPs. And you could find a third RDRP disruptor as well. And so why did Merck has to go and say, you know what, we should create an RDRP disruptor? Because I think they found out that ivermectin shows efficacy if we disrupt RDRP. And they said, fine, we'll make an RDRP disruptor. That is what my point was. And I still believe in it. I still think that ivermectin will still be superior because ivermectin has a chance to bind with these spike proteins, disrupt RDRP, disrupt MPRO protein, disrupt the importins, and modulate NFK beta. That all is not in molnupiravir.
And thankfully, it sounds like we are going to get a definitive answer with Active 6. Provided that the trial is designed properly and not designed to fail. Trial design is a big deal. You can hurt a good drug by a bad trial design. But thankfully, I have confidence in the NIH that they will design the trial properly to give ivermectin a fair chance to succeed. So thankfully, we'll finally, how many months into this, 18 months, we'll finally get a definitive government-funded study of ivermectin.
Got it. So some quick answers to the questions before we go to long COVID. I know that the time is going by as well. So Colin Hamill, so we are quite behind in our questions. Colin Hamill he's from UK. Should people's medical record be checked before administering a vax? Meaning, do they need it or not? Should we see if they were already infected? If they are, they're already protected, don't need a vax, or hey, just keep giving vax to everyone?
I think there's some studies out there that show that if you've had COVID, Dr. Patterson, and I think Dr. Patterson's a genius, would argue that, and has said this publicly, that if you've been vaccinated, he doesn't feel that you need to be, or if you've had COVID, you don't need to be vaccinated, that natural immunity will carry you through because your humoral long-lasting immunity will take care of it if you get reinfected. Now, granted, I'm not endorsing that. That is not a mainstream opinion. I think there's a lot of literature suggesting that if you've had COVID, you would only need essentially a booster instead of the 2-dose regimen. I mean, I feel comfortable saying that will probably, I feel comfortable saying in the future, I think the literature, that will become a consensus opinion. Right now, there's papers, but I think that will become a consensus opinion.
Agreed.
In the future.
So my opinion is that very similar to Dr. Bruce Patterson, and we came up with those opinions, I think, independent. I did not have this discussion with him. My opinion is if somebody has gotten the infection and recovered from it, they do not need a vaccine of any sort for COVID unless their immune system has changed between point A and B, or the variant has changed enough. For example, as you're saying that maybe a booster is needed at some point because the variants are different. Otherwise, vaccine not needed. And then I want to strengthen your point as well, that if somebody does decide to have a vaccine or they are asked to take a vaccine, then we did a studies review here where after the infection, 1 dose of a vaccine, the first dose was sufficient to bring the antibody levels back up. And the second dose did not do any significant change. So 1 dose may be sufficient, if at all. All right, I'm going to go to the next question. Luis Grande says, what is the treatment protocol in the ER? And is there a standard treatment that you must adhere to Are you able to prescribe therapeutics that are receiving pushback from the medicine overlords? Totally up to you to answer as much as you want.
Sure. So in the emergency department, hospitals are very complex organizations. There are a lot of restrictions to what I can do, what I can't do. So in the emergency department, care was generally limited to supportive treatment. So I would oxygen stabilization, whatever oxygen support they needed, intubation, BiPAP, high flow oxygen, low flow oxygen, whatever oxygen you needed, stabilizing treatment, mostly, supportive, the ABCs, airway, breathing, circulation, stabilization. And then we would generally give if they need to be in the hospital, they are hypoxic. We would generally do the first dose of Decadron in the emergency department. 6 milligrams, either oral or IV. And that was pretty much as far as it got in the emergency department. Now, I will say that when things were really rough, circa, November to January, February, a lot more things were being done. If there were, we would get their elevated inflammatory markers. We would consider starting Lovenox in the emergency department, antibiotics based on, inflammatory markers and those sorts of things. But in general, it was very limited to just supportive care and Decadron. The other medications that could be used, and one of the things I've been on the record about being frustrated about as an emergency physician is there's really not a lot of other medicines to use, I've been very honest, I'm not a proponent of remdesivir. I don't think the literature supports it. Was that it's infectious disease restricted, meaning that you could not, even if I had wanted to give remdesivir in the emergency department, I would not have been able to because it would have had to be ordered by the infectious disease physician. And even the hospitalist in the hospital couldn't order remdesivir. It had to be ordered during daytime hours. So really, a lot of the things that we could do were, and that's not just unique to COVID. There's for certain antibiotics, you got to get infectious disease approval, things like that. Like I said, these things are very complicated because what they don't want us to do is pick the wrong antibiotic, breed antibiotic resistance, give somebody a C. diff infection. There are very well established reasons for why these things are done this way. Because obviously, the biggest thing to hospitalists is first do no harm, keeping patients safe, and these mechanisms are in place to keep patients safe. But that's generally what the care was limited to in the emergency department. But if somebody asked a question, I'll answer it honestly. There's really, as far as overlording or I really didn't experience anything like that. I didn't feel like there's anybody that was hovering over me, questioning what I was doing or anything like that. I think most of my frustration was that, hey, I've seen these studies on, tocilizumab, all these other Viptidil, all these drugs, even still, possibly, leronlimab, everything that may work, and there's not available to you. And so that was the frustrating part. That, hey, I've got this, patient here. I've just intubated them. Put a central line in them. They're very unstable. I'd like to start them, in addition to Decadron, on some sort of immune modulator to help increase their odds of survival, but it's just not available to you.
Got it. Thank you very much. M. Gregory says, they are predicting this autumn to be bad COVID season. Do you agree?
I would not. Well, it'll be worse than it is now because it's very, very low level currently. Do I predict that we are going to have another massive wave that fills up the ICUs and fills up the hospitals? No. But I do see I think it'll be relatively significant, but I don't think it will be anything like what we saw in the past, because I think the vaccines are going to be relatively protective against the Delta variant. I think we'll see more breakthrough infections, but I don't think they'll be severe. I don't think there'll be a lot of severe infections that'll require ICU stay, hospitalization. So I would say it's going to be a lot like the UK data that Dr. Bean just showed us. There's going to be an increase in cases, but I don't think that there's going to be a significant impact on hospitals, excepting for in areas where vaccination rates remain very low. I do think there is the potential to have some hospital overcrowding and issues like in those areas. But in general, I think it will be relatively modest, and I think I don't think that it'll break the system or overwhelm the system.
Got it. Few more questions before we switch to long COVID discussion. William Goff, he is a healthcare professional. What other vaccines or medications have Matrix M been used in, if you are aware?
Yeah, that is Novavax's patented adjuvant. So this is the first vaccine that Novavax has brought to market. So this will, while they are doing other vaccine trials. They just had a successful anthrax trial. They've done RSV trials in the past. So they've used it experimentally in other trials. It's just obviously the first sounds like commercially available product that it will have been used in.
Got it. One more quick question. James Nguyen says, if they are 92 on a pulse meter, do they get oxygen in your emergency room practice?
So that's that's actually a very good question. So the answer to that question is it depends. What I generally do, so generally if your stats are over 90 with return precautions. Now there was an interesting study that came out about occult hypoxemia in African American patients, and what they found was essentially if I had a stat of 92 and they did an ABG on me, my stat's probably going to be 92. I mean, an ABG is an arterial blood gas. That's where they stick, essentially putting an IV in an artery instead of a vein. You can think of it like that. You're puncturing the vein instead of the artery, and you can directly read what somebody's actual oxygen saturations are in their bloodstream. What they found was when they did that in African American patients, there is a discrepancy between what the pulse oximeter read and what their oxygen levels were in their blood. So what an oxygen stat of 92 would point out to me is I probably would get an ABG to evaluate for occult hypoxemia, and I would let that be my determination. And also, what does the patient look like? I could have a stat of 92, and probably compensate. Really, I might be, and probably compensate very well because I'm 38, I'm healthy. I run, 15, 20 miles a week. I can tolerate a stat of 92. There are other people that can't tolerate a stat of 92. So it all depends on, they're also on their comorbidities and other things like that. But I do think if there are any physicians who are watching tonight, I think that's not just in COVID, but just in general, if it's occult hypoxemia in African American patients is a real issue. And I think that goes to just not all patients are the same, and we have to be very cognizant of, that's why when we do these vaccine trials, like Novavax is having to do a separate trial in India, they're having to do a separate trial in Japan, a separate trial in UK, a separate trial in the United States. Just not, all people are different. And so we have to be mindful when we're treating patients that, based on, ethnicity and gender and all those things, all patients are different. So it's a very interesting study. I've linked it on my page, Bream Medical, several months ago. But it's definitely occult hypoxemia and non-Caucasian patients, or especially African American, is something to be mindful of.
Got it. So I have a couple of questions. There are more questions here as well, but this is something that I'm very curious about. So it'd be great if I can have your take on it. The vaccine-induced clotting and vaccine-induced myocarditis. Mm-hmm. Have you seen such patients, or seen or not? Do you have a protocol that is approved that, hey, if somebody has gotten the clotting, they come to you, or do you use your regular protocol for managing? How do you manage them? Is there any additional talking points, protocols given to you to say, do this? What is your prep on that?
So all the hospital systems sent out a memo for CVST, reminding us not to treat it like we normally would treat a cerebral venous sinus thrombosis that we talked about last time. That heparin actually, because it's an autoantibody to HIT4, that heparin actually worsens, and that you need to use Drbeen. So we all received education about that. I hope every emergency physician in America knows that at this point. I feel confident that the vast majority do. So we all did receive education about that. I have not, in my clinical practice, seen a significant amount of venous thromboembolic events comparatively in vaccinated patients. And I think the data, we're using Pfizer and Moderna mostly. Well, actually, what we're pretty much using in the United States right now. And their data is pretty congruent with that they didn't see a major increase in just general DVT, PE comparatively to non-vaccinated patients. What I have seen is a few cases of what I would relate to myocarditis. I have seen some patients, and I have some other friends who have seen some patients who have had SVT, either an mRNA vaccine, which I would attribute to some sort of myocardial inflammation. It's been fairly easy to treat. Generally, one dose of adenosine and beta blocker, check some labs, make sure there's nothing else going on, discharge on the beta blocker, follow cardiology for an echo. But the cases I have seen with super SVT is when your heart just is beating very quickly, usually depending on your age, somewhere 160 to 190 beats per minute. We treat that symptomatically, and the patients seem to do pretty well. I have seen several cases in the PASC realm of what I would consider persistent myocardial inflammation with inappropriate sinus tachycardia. I've seen lots of patients who come in status post-COVID, and their resting heart rate is just 130, which I suspect is due to some underlying myocardial inflammation. They are using beta blockers for that. As part of symptomatic treatment. Something like that, I would feel relatively comfortable writing for a beta blocker at discharge, just because that's something that I would commonly write for regardless. So those drugs I do feel very comfortable writing for people at discharge. But I have seen, as far as myocardial events, that is some things I've seen. And then post-COVID, I'll kind of share a sad story. My cousin, Junior, he lives up in Ohio. His dad passed a couple weeks ago, and he was 76. He had cardiac disease. He had a bypass. He had severe ischemic cardiomyopathy, meaning that his heart was enlarged from not getting enough blood flow after his heart attack. He had to wear a life vest for a while, and then his ejection fraction, meaning how well his heart beat, recovered to the point where he did not need a defibrillator. And so, but then he ended up getting COVID and developed worsening of his cardiac enlargement. His ejection fraction went back down to 20. He went into pulmonary edema, meaning he had fluid all over his lungs, got intubated. His heart was beating so poorly, he couldn't get enough blood to the rest of his organs. He went into kidney failure, and he passed away. So you are seeing these post-COVID, cardiomyopathies and enlarged hearts and things like that are also very real. So there are significant cardiovascular effects from COVID that I have seen.
Got it. And my apologies, I had to take a sip from my coffee. I had a throat that started itching. So cardiac inflammation, while we are on that topic, and it looks like we may have to actually request you to join us once more for long COVID, or you would decide if the time is okay. I want to quickly get your take on this. So here is the CDC today coming out and saying, so the context, I would put that in front of you first. The context is Dr. Bream, you okay. So I
Yeah, I'm
thought
with you.
the context is that CDC knows that 53% of the myocarditis is occurring in children between the age of 12 to 24. I think that off the top of my head. And that population is 9% only of the population that is vaccinated. So 9% of the population, but 53% of the cardiac inflammation. Uh, and with that context, CDC came out today and they said, we recommend getting vaccinated right away if you haven't yet. It is the best way to protect yourself, your loved ones, your community, and to return to a normal lifestyle and safely and quickly. So what they're saying is continue to go forward with the children's vaccination with that risk. And once again, it was expected that they're going to come out and say the facts are very clear and this is a rare event. How do you see it? Should children continue to? And again, if you wanted to pass on the question, totally do. I don't want to put you on a spot. Should children get a vaccine when the risk of the inflammation is 50% in them, or compared to all the inflammations?
I will have to. Well, see, because if I don't answer the question, I answer the question. It's kind of those things. I mean, I do think that children. It's interesting because you could, as with everything in medicine, I think this is a shared risk benefit alternatives discussion with the family. There is obviously this risk. As far as I'm aware, that they are not, now granted, this is new, and these trials are on the patients who are adolescents and younger are very recent. I am not aware, although I don't think anyone would really be aware at this point, that there's any long-term damage from this myocarditis. So from everything I've read, it seems to be a transient, mostly benign thing. So I think it all depends on your risk-benefit tolerance. I think that if there is a child who is immunocompromised in any way, there is someone in the house who is immunocompromised, or anything, if you're living in the house with like a newborn, a type 1 diabetic, common variable immune deficiency, cancer, anything like that. If you're living in the house with any child like that or any adult like that, then absolutely, yes, 100% get the vaccine. Don't ask questions. Don't pass, pass go, collect your $200, be done. I think there's a little bit more wiggle room in the healthy children. Now, there is, and that's where you talk about these risk benefits. So by getting the vaccination, young healthy children are not dying. I've not verified this, but if you listen to Dr. Makari out of Hopkins, so I'm sure you've listened to stuff, he says that there has not been a single death in a healthy child from COVID-19. I have no way of verifying if that's true or not. But that's what he says. And, he would advocate, I'm not saying I would advocate, but he would advocate for young, healthy children don't generally need to get vaccinated. And that the argument from is that, children can stop, vaccinated children will help decrease the spread because children are efficient vectors, and that it will prevent MISC, multi-system inflammatory syndrome, from developing, which is a rare, generally treatable with steroids complication of COVID-19 in children. There have been 300 or 400 cases, I believe, roughly. So you have to give the parents, the risk and benefit and let them make the decision.
And I would, sorry.
So I won't necessarily punt. I just think everybody's risk tolerance is different. And I think it would be different in the vaccines, because I obviously feel more, Novavax is having their trial right now. I would feel a little more comfortable with, that vaccine versus maybe Pfizer or Moderna in the kids. But I really think I think it's a risk benefit discussion. I can tell you personally, I don't have a strong feeling either way. I would not fault at this point. I wouldn't fault anybody either way. Especially because it's so new. If families were apprehensive, I would discuss all that with them. That MISC, the rate that is low, the rate of myocarditis seems to be relatively low, maybe higher than maybe it's unreported higher, but it seems to be a transient effect. And it just really depends on what their risk tolerance is. So, so I don't know.
I'm going to actually help you out here as well. This has been a topic that has been difficult for me as well. My reasoning is that there's been a child in very close family, 19 years old, who died. And the trauma with his parents and with us, it is still there after years. And so I see how a child's death can cause devastation for the family. And so now if you say, go take a vaccine and there is a side effect of the vaccine and that causes an issue, then you feel bad. And if you say, don't take a vaccine, and if the child becomes infected and has bad outcome there, then you feel bad. So this is one area where I have been very, very, I have not been able to make a decision or suggest something. So for me, I have been coming to the same conclusion to say, here is the data, and this is something that parents, families, doctors, communities, they will have to come together and make a decision for themselves. Although from CDC's point of view, once again, what I fail to like about CDC's stances are, they say, well, keep going. In my opinion, they do not create enough of the safety protocols to say, if a child is going to be, now that we know that if you are vaccinating a child and they have a higher tendency to get the inflammation, cardiac inflammation, then here are the ways to protect them, or here are the ways how we will help them and we will save them and their heart will be saved. That to me, it seems like indifference. It then becomes a duty of folks like you who are in emergency to figure out, how do we work with that? How do we save the patient? How do we save their heart as well? Mm-hmm. I want to ask a couple of, sorry, do you have a comment before I ask the next question?
No, I would just say I would definitely, where I would think I would leave it is, I would never discourage a family from getting their child vaccinated, for mm-hmm. sure. I mean, I would certainly, I would never discourage them. Mm-hmm. But yeah, I do think, like I said, I think it's mostly just a risk-benefit discussion at this point. Now, I would say I hope to become more convicted that getting the vaccine is the right thing to do as we get more data. I mean, I'm just mostly on the fence right now. I just want to see more data.
And we can feel that. And thank you very much. And it's totally fine. I don't want you to take a position at this time. So I have a question here, and this is a common question that has been discussed here or popped up here in Coolbean's discussion, I'm sure outside as well. What is the reason of the myocarditis? Is it the antibodies or the cytokines or the spike protein itself going and damaging the heart? Do you have some thoughts or observations that in case of post-vaccine inflammation or post-COVID cardiac inflammation, what is it that causes the heart damage?
As far as I understand, as I talked about earlier, I think it's mostly just from the presence of the spike protein that alone can do that.
So you are thinking that after a vaccine, there may be spikes that would go to attach with the cardiac tissue and cause inflammation there?
Yes.
Okay. Cool.
That's quite possible. And I think you've got Dr. Patterson coming on. I think he'll be the authority on exactly telling you how that happens.
Yeah. So the studies that I've seen so far, or the conjectures so far, it is all a hypothesis. Mm-hmm. These have been that there is a molecular mimicry. So when the vaccine is given and the antibodies are produced, those antibodies are accidentally attacking the cardiac tissue.
Right.
Mm-hmm. So that may be possible too. There is a question or comment. William Goff, again, he's a healthcare professional. Unethical. I feel it's unfair that COPD doesn't qualify for monoclonal unless 12 to 18 or 55 plus. I'm 46 with COPD, so I intend to pretend I'm DM2. Do you verify comorbidities before monoclonal antibodies?
I mean, I would say
Totally,
that's.
you can decide to say yes or no.
I mean, I would say COPD is a high risk condition.
Yeah.
I wouldn't deny somebody monoclonal antibodies because they, I think COPD is certainly on the risk of high risk conditions. I don't think people should be denied just because for COPD. I mean, if they have COPD, that's a high risk condition. So yeah, I would think that patient would be a candidate for monoclonal antibody and shouldn't have to, fib that they're a diabetic as well.
Got it. So we are almost 1 hour into the talk. How about so one request, I still need you to come back and talk about the long haul. That is very important, post-COVID and post-vaccine. So one, can I have an agreement that we can request your presence once more?
Absolutely.
Okay. So with that, I have a few more questions here that are similar, in the similar vein as the topic that we're discussing. One question here is, and I want to, so this is, okay, I'm going to skip this question. And the person asking that, would you agree on mandatory vaccines for children in college going or not? I don't want to put you on the spot for all of those decisions. Totally your choice to answer it or pass on it. I would pass on it and say, it is the community, the parents, they have to come together to make a decision.
Well, I would, just give you the answer my friend Luke gave me, who's a lawyer. It says it really doesn't matter what you think. These entities have, especially as he says, and especially in at-will states like North Carolina or many states in the South, it really doesn't matter. If your employer requires you to get it, you have a choice to make. You can get it, or you can find a new job that doesn't require you to get it. It's just for private corporations and private entities can pretty much make you do whatever they want, and that is well within the limits of the law.
Makes sense. Jody says, if not confident that hospital is able to meet needs of a patient, what options does patient have? So let's say if you feel that, hey, we cannot offer you all those because of our protocols. Do patients have other options as well? Of course, we know that there are ivermectins and other things. Right. What is your take on it?
So there's obviously, the Medicare Bill of Rights that tells you exactly what your rights as a patient are. And then if you feel that you are not getting adequate treatment, there are certainly many avenues you can go down. Most of and this becomes, I think, an issue at probably, some of the larger hospitals. I think most smaller or critical access hospitals are keenly aware of what their capabilities are and what they should and should not be keeping and what they should not be taking care of. I think they are very diligent about patient selection, what is safe to keep at the smaller critical access hospital and what should be transferred to a larger facility. If you don't feel like you're getting the care you need or deserve, the first step is always to tell that to the physician who's caring for you. A lot of these things can be resolved by just having a conversation about, because it's like medicine is not any different than marriage or friendship or anything like that. And coaching, having been a medical director for quite some time, where disagreements happen with patients and families is where somebody's expectation, their expectations are not aligning. And so you need to reset and figure out where is the disconnect between people's expectations. What is the expectation you have that I'm not meeting? And a lot of times we can just with that conversation come to an agreement about what we are not doing that's not satisfying you and take it from there. If that doesn't work, then you can go to most larger hospitals have patient advocates. I know we had patient advocates in the larger hospitals I work at. We have patient advocates who are there all the time, and that is literally their job. They're rounding in the emergency department. They generally try to see every patient while they're there, and hey, how's your care going? Is there anything, any issues I can help out with? And they're like, yeah, actually, I don't feel like I'm getting great care. I need this or that. And they write it down, and then they either come talk to you, or if it's something that can't be resolved, they go up to the chain of command. So I think option one is always ask for a patient advocate. Two, if you really can't get where you're going with that, then really there are always administrators on call for every hospital, small and large. You can ask to speak to the administrator on call. Now that's a relatively big step to take. But we do have patients where that has been an issue, and we can generally get it resolved. Three, hopefully things don't get to this level, but they have. There have been some, and there's some very interesting debates among physicians about this, is when patients have gone and gotten court orders from to get trial drug access. Like I think ivermectin has famously gone through a couple of those scenarios, because there is right to try is a law. And I think a lot of physicians are bothered by that. It doesn't bother me at all, because I feel like if this drug might work, I think you should be able to get it if you're critically ill. There are other physicians who feel like a judge who doesn't have any medical training shouldn't be telling them what to do. But that is, and then in that case, you need to buckle up for a legal battle. If you're going down, it shouldn't be that way. But that is your last resort option, is to go the right to try legal route. Now, most everything can be resolved before it gets there, but those are your pathways of action.
Got it. Thank you very much. One last question. And again, I do not know if Chris, who is asking this question, has the data to back it up as well. Chris says, there's been data from the UK that the vaccinated people that were infected with the Delta variant had higher death rates. Could this be a sign of ADE?
Well, I guess I'm blanking on the ADE. I mean, he is correct.
Enhancement.
Oh, okay. He is correct that there does seem to be a higher incidence of breakthrough and death from the Delta variant. I think the number was 29%. If that's the number that's coming to my head, I do know I read the article about it. I think that 29% of the deaths in the UK, somewhere in the 1/3 ballpark or so, were in vaccinated patients. Is from antibody dependent enhancement? It would just be conjecture. I really don't know. More so to just escape immunocompromised, just poor immune response. It's hard to know exactly what the exact mechanism would be, but he is 100% correct that there are, in the Delta variant, they are seeing a higher death rate in vaccinated individuals than they were in the other variants. But I don't know that I have seen, and it needs to be figured out, but what the exact mechanism for that is.
Got it. I said that was the last question. Promise this is the last question.
You're sure? You're fine.
JLB says, more objectively, if the hospital does not use or allows it to be used, for example, ivermectin, how can we have it?
I mean, you have to be prepared to go to the mat, for it in a legal way. I mean, like I said, try to advocate. Try talking to your doctor, and I would approach it from, bring them the articles. They may just not know. It is very difficult in this rapidly changing environment, and I'm not quite as up to date as I was, a couple months ago. I still read a lot, but I'll tell you, I'm working a ton right now. I think this month, I did finally go on vacation for the first time in almost a year and a half. But even this month, I'm still working 170 hours or so. With a week of vacation. Next month, I'm working 230 hours. Next month, I'm working 240 hours. So I'm working a lot, and I travel a lot too. So I don't, it is relatively difficult to keep up with all of this. So I would appreciate if a patient brought me something and said, "Hey, I'm interested in this drug. Here's the data," because a lot of times it's I think physicians tend to be embarrassed. If somebody brought me, and the last thing, I'm a pretty straight shooter. If I don't know something, I'll just tell you I don't know. I'm not going to try to make up something to sound smart or anything like that. If I don't know, I'm just going to tell you I don't know. But if you came in, you're like, "Hey doc, I've heard of this drug, Fostamatinib. It seems like it could maybe help." I'm like, "Oh, okay. Now, well, what is that drug again?" Because it's not something, it's a cancer drug. I'm like, "Well, here's this paper I read about it. What do you think?" And I'm like, "Oh, okay. Well, no deaths in placebo, and 3 deaths in placebo, 0 deaths in." Okay, yeah, sounds interesting. Let me see what I can do. Versus just coming in guns blazing. "I want ivermectin." Oh, okay. Well, we can see what we can do. Well, and explain. You get a lot more. You attract a lot more, butterflies with honey than vinegar. A lot of this is just how you approach it. If you come in guns blazing, adversarial, I demand I get ivermectin. Okay, well, let's slow down. Let's talk about why we were getting ivermectin, and if you get pushback like, "Well, here's some studies. I saw Dr. Bean's excellent talk on this. I'd recommend that you spend 45 minutes watching this tonight, and maybe you'll change your opinion tomorrow." And then if that doesn't work, then because I think you just have to be aware. I'll be honest, I think a lot of physicians just aren't aware, and I think there are a lot of physicians who get their treatment cues from the mainstream media. Because that's what happens. You get something, alert on your phone that blows up or something like that. They just may not be aware of, linzilimab, leronlimab, abiptidil, fostamatinib, allocetra, all these different drugs that calcifediol, all these drugs that are out there that have some reasonably good literature behind them. They just may not be aware. So I think that's a big part of this is, having the ability to make the physician aware of the drug, why it's beneficial. And I think most physicians are pretty reasonable people that if you can bring some evidence that says, "Hey, this is now, and this looks good," the risk benefit, I think the benefit way outweighs the risk. Then I think most physicians would, now granted, this is where there is some overlording that could occur. The doc could be okay with it, and then the hospital says no. That's when you get into big problems. And that's where I think you have to be prepared to talk with hospital administration. You have to maybe talk to hospital legal, those kinds of things. But unfortunately, legal counsel is not cheap. And so it's very difficult to go that route. And it's just very, very unfortunate. But that is the avenue you sort of have to take, that if you want something you feel like, or after discussion of the risk benefits, you're not getting there, after discussion with patient advocate, you have to just say, look, basically, it's right to try time. And, that's how we have to do this. But hopefully those things can be resolved. But it sounds like in a lot of cases, it's not, unfortunately.
Got it. So the parting last topic, you had proposed to discuss these 2 drugs, allocetra and fostamatinib. I want to talk about allocetra and maybe fostamatinib next time. Allocetra fascinates me. Tell me a little bit about the mechanism. This was such a cute mechanism of action. I loved it. Can you give us a little bit of an idea of how this drug works?
Yeah, so basically they put billions of apoptotic cells into the bloodstream, and basically use the body's own natural mechanisms to rebalance the immune system. Basically, in the short term, macrophages come in 2 types. You can think of as good and bad, anti-inflammatory and pro-inflammatory.
M1 and M2. So
right.
cool beans are aware of that.
Yes, and so basically what this does is it uses those apoptotic cells to reprogram your macrophages from pro-inflammatory state to anti-inflammatory state, to help calm the cytokine storm, macrophage repolarization. Allocetra does that. Obviously, leronlimab does some of that, and I think when Dr. Patterson, in his COVID treatment protocol, I believe he says Maraviroc does that. So there are multiple drugs out there that do this, but this is IV infusion, and so basically this is a novel therapeutic out of Israel. It's got a very small subset of data. We're at a phase 2 trial. I think phase 3 will be starting relatively soon. But 21 patients in a phase 1b/2 trial. There 11 out of the 21 were severe, 10 out of the 21 were critical. And the big mind-blowing number here is 0% mortality on day 28. Granted, it's only 21 patients, but some of these patients were intubated. Half of them were critically ill. So we would expect in the critical population, somewhere around a 30 to 50% death rate, roughly. And their death rate was 0.
Wow.
So every patient survived. 19 of the 21 were discharged on day 28. 2 out of 21 were still intubated. The average length of hospital stay was 5.6 days. So I just think it's a very interesting drug. I think it's a long way away from being available, but in talking about these therapeutics that are out there, this is one that I don't think has gotten really any attention or any discussion. It's one I found probably a year ago, just in reading a lot about these, a lot about the data. But that is, I think this is very interesting therapeutic, certainly an emerging therapeutic, and one that we should be keeping an eye on. But I think there, like we said, I think there's lots. Fostamatinib. I think we'll talk about long hauler. It sounds like next time. I think the phase 2 leronlimab long hauler data is interesting and certainly deserves to be discussed. Although they've got to prove that in phase 3. I think there's a lot. There's some other interesting drugs out there that certainly should be discussed more.
I think we should, and I'm going to ask Melissa, my assistant, to speak with you to see what is your schedule and when we can have you again. This, while you were talking about it, I was just continuously smiling. I'm a mechanisms guy, and for me, what was interesting was that this is a angry M1 classical macrophage who's saying, "I'm going to kill everything around me."
Mm-hmm.
And then you say, you know what, macrophage, take these all little cells, they're about to die, kill them. And it kills them and says, oh, right, I need to get into the repair mode now. I need to become happy. I've already done a lot of killing.
Mm-hmm.
And this feeding, the baiting of the macrophage by these saying, oh, all right, you're angry, kill these. And then macrophage converts into M2. And that is such a cute way of converting it. So if you see here, it says, with infusion, the body's macrophages and dendritic cells can feed on these early apoptotic allocetra cells and thus result in the macrophage and dendritic cells releasing fewer cytokines and converting. This is such a cute mechanism. Thank you very much for bringing this drug to our attention and discussing it. So I'm hoping that we can, you said that you're going to go out for a vacation too. So I'm going to try to get you back as soon as we can. And
I just got home. I went to Aruba last week. It was awesome.
I see. So you're done with the vacation. We can have you soon.
I was back to work this week. I worked day shift on Sunday, 4 to 2 Monday, 4 to 2 yesterday, off today. Big news. I'm interviewing for a medical director position in the morning. So
you'll get it.
I gotta once we get off here, I got to do a little preparation for that, and then I'll be on the road early in the morning for that interview, and then back to work Friday, Saturday, Sunday. So it's a busy week.
Prayers for you and best wishes for you for your interview, and thank you very much for your time.
No problem. Thank you, Dr. Breen. I greatly enjoyed it, and we'll look forward to doing it, talking some long haulers soon.
Thank you very much. And Cool Beans, thank you very much for your time as well. Tomorrow we'll have Dr. Bruce Patterson with us at this time, 6 o'clock. I think it is going to be a very important talk because his team, as Dr. Bream was talking about as well, their work is worthy of a Nobel Prize. So we're going to talk about what their work is, what have they found, and what are the implications of the management in light of what they have found. So with this, thank you very much, and I would see you tomorrow. Dr. John Bream, once again, thank you very much for being here.
Thank you, Dr. Bream.
Bye-bye, guys.